Welcome to the Postgraduate Pediatric Orthopedic video series. And I'm Sattar Alshryda. I'm a pediatric orthopedic surgeon. In this video, I'll continue what I started in video 23.2, which is tibia shaft deformity correction using the TL-HEX support. We saw in video 23.2 how to do the preoperative planning. And in this video, we'll continue to do the operation technique and the postoperative planning and correction. From the preoperative planning, we planned our frame, the size of the ring and the size of the struts and how the shape of the frame looks like. Also, we designed where we're going to put it in relation to the joint surface line. So what we need to build our frame first, then apply it to the bone. Once we did our program, we'll come to build our frame even before we go to theater. These are two rings, these are full rings, and the size of them usually written on the side. This is 1/6mm ring. This is what we're going to use as proximal and distal. If you look at the frame, there's a line here and there's a line opposite to it, exactly here. Okay, and this is the center of the frame. Okay, so we have the size is 130, it is full, and this is the center of the ring. Okay, and we're going to use two rings. For the struts, we need to build our strut according to what we programmed earlier. Each strut, we have different sizes written on the back of the strut. This is long, there's medium, there's short, and there's extra short. So this is our ring. Now, strut number 1, let's do the strut now. Number 1, and strut number 2. This is number 2. So, our frame. Okay, so you put this one, then 3, and 4, and 6. Okay. So if you see, these not haphazard, they were numbered from, if you look from the bottom, number 1 here, I always tell people, like, if you imagine this clock face, this is 12 o'clock, 1, 2, 12 o'clock, they go 1, 2, 3, 4, 5, 6. Follow the clock. If you look from the top, it will be the opposite. Okay, and you can see we skip. We put it in one angle, then we skip one, then we put it. Okay. Our frame is finished. Now we need to, the most important thing really is to make sure it looks like our preoperative frame. So if I look at this one, does it look like my frame? If I have to match it, I put this one, make this look like a ring. This one, to me it does. Then you look from the side. We make this like a ring, it looks perfect, exactly as we expected. Having completed my frame according to the preoperative plan, I usually send it for sterilization to be ready for a theater day. Some colleagues, I know they give it to the patient to keep it with them for a few days to play with it, try different parts, and sometimes even they execute the program before the surgery. so it will become less intimidating and they know the different components. Also, from the preoperative planning, we knew where we're going to put the frame, how far it is from our reference point, which is in this case the knee joint surface. So all set to do the surgery. Doing this will save a lot of time during the surgery. However, it needs some practice before you become very slick at it and you become comfortable in using already pre-assembled frame to apply for the deformed bone. Okay, so we usually mark the joint line, and as we planned our frame, it's going to be 155 from our joint surface line. So this is our, it's going to be 155. So here it's going to be our proximal reference ring, 155. And our osteotomy side should be 232, which is here. Okay, so when we get the patient, our frame, it's going to be somewhere like this. Okay, so what I usually do, I create what I call polyaxial hinge. These, some of them, they really come commercially available, or I can create them. By connecting one hole rupture to a hinge. Polyaxial hinges allow us to position our ring in any way in the space. Okay, so bring my frame. I put my frame, usually put it from the bottom, this model. This is what I'm going to think is going to be there. My assistant will hold it in where we plan it to happen, which is there. Okay, I put my polyaxial hinge. And I use my yeah, that's probably perfect. Okay, now I'm going to tighten everything. Perfect. We're going to tighten everything. This polyaxial hinge would allow us to readjust if it's not perfect without having to drill again. Okay, but the look seemed to be okay. So this is from here. Seem to be perpendicular. Okay, good. So once I finish with this one, I'll put my bottom rig. One to try to get it on the outside of the rig. So we tighten the bottom one. Once we tighten two of them, the frame will be relatively stable. Okay, good. Now we are happy with the position of our frame. We just fill the gap. We put two on either side and one inside. Okay, good. Here I'm speeding the video for the sake of time. It's just a matter of filling the rest of the fixation. Each ring must be stabilized by 3 fixation with a half pins or wires. I prefer to use half pins, particularly HA coated one, because they have less problems of infection or loosening. From a mechanical aspect, 2 fixation per ring is enough, but the problem is that if one of them gets loosed or infected and you have to remove them, you would left with 1 which is not enough. So we normally use 3 in anticipation 1 might get loose and we have to remove it. It goes without saying that the insertion should be safe using safety corridors within the limbs. There are several books that can guide you how to insert half pin or wires. One of these books is the one I'm showing here in this video, which is called the Atlas for the Insertion of Transosseous Wires and Half Pins, the Elizarov method. It has nice demonstration of these safe corridors or where you can insert these wires. There are several frames available now. We prefer the TL Hex for the reasons I mentioned in the previous videos, but the other frames are adequately good. It's really important to know which one you use. You should be very familiar with the hardware components and the software components. Also, the principles of applying them and executing the program is the same, but there are some individual variations that might thrill you. For example, one of the thing in TL Hex, when you lengthen the number on the gradual scale, they get less and less, which is counterintuitive. But if you don't know this, it can cause confusion. Here I'm reaching to the end. I think I'm putting the last half pin for this frame, and I'm tightening now. So once we complete the whole fixation, we will do our osteotomy. The way we do our osteotomy, we remove the front struts and we use whatever technique you use. In this model we use the normal hex. But of course in theatre you could use the jiggly saw or you could use the drill method. The most important thing, whatever osteotomy you use in theatre, should be low heat generating and respecting the bone and doesn't cause osteonecrosis. This will help you a lot later with healing of your osteotomy. And this is the postoperative X-ray. It is AP view, orthogonal on the proximal ring, which is a reference ring. By orthogonal, I mean the ring looks like a line, as you can see with this green arrow. For TL Hex software, you don't need to take the orthogonal views for the reference ring, as the software can calculate the parameters regardless the position or the shape of the ring. Also, you can see there is the calibration ball, which is highlighted with red color. This is 25 millimeter size, and it helps with the estimation of the magnification of the X-rays. If this is not available, you can use the width of the ring, which is 10 millimeter to help estimation of the magnification of the X-rays. And this is the lateral view as well, which has almost the same features of the AP. You have the orthogonal proximal ring, you have the calibration ball, and the osteotomy size should be visible. And now, having finished the operation and we obtain the postoperative X-ray, we go back to the software for final programming. We go to our list of cases and we click on the case, not the patient, the case, because this is the case we want to edit. So once you click on it, it will bring you back to your case data entry, the deformity parameters, mounting parameters, schedule, and so on. And we've seen this in the preoperative planning. There's nothing changed from the first one, so you can move right away to the deformity analysis. In the deformity analysis tab, we still proximal referencing, and we have the data already populated from the preoperative planning. But things can change during the surgery, although it is minor. So you click on Hex X-ray, and as you can see, this is the preoperative planning. But at this stage, we are postoperative, so you click on the postoperative tab. And again, it will ask you to upload the postoperative X-ray, which I think I've saved it. And like in the preoperative, it will ask you, are the orientation correct? So let me make it smaller. This is the bottom, this is the top, this is the lateral, this is the medial. So there's various deformity. I would say yes, this is correct. Then it will ask you for the calibration, and you can see here is the calibration ball. So change it for circle. Magnify it to make it easier to okay, happy with this one, and this measured is 25 millimeter. Yes, then it will move to the lateral. We upload the lateral, and this is the lateral. Again, we'll ask you for the orientation. This is anterior, this is posterior. I think this is correct. And this is the top, this is bottom. Yes. And again, we'll ask you for the calibration. It is a circle. If I magnify it, and I move this to be on top there. As you can see, I'm going fast because we went through all these steps in the preoperative planning, so it shouldn't take more time. And now I have the multiple images, anterior and posterior. Here, you remember in the preoperative planning, the software asks us to put a reference point. Here, the reference point is the osteotomy really, because it is the same on both sides. So place osteotomy, and let me magnify this one. Our osteotomy was here, and on this one was once I'm happy, I will lock it. Okay, it will move to the next part. So let me readjust them. So make it in the middle. Again, bring this to the middle. That's about right. In the middle of the bone. Slightly this end here just to get it to the middle of the bone. And again, this is get it to the middle of the bone. Little movement. Okay, good. And this one again on the AB, get it to the middle of the bone. And bring this down. The middle of the bone, maybe move this slightly. Okay, so I have 28 degrees of varus, I have 5 degrees of recurvatum. So during the osteotomy, during the surgery, we sort of corrected the procurvatum and we created some recurvatum. So I'm happy with that one, so I'll lock it. Then I'll go further to the next line and show me the correction after that, which I'm really happy with, a straight bone on both AB and lateral. Happy with that. So it will give me a lengthening of 6 millimeter by the virtue of correcting any deformity. It will make it longer, and also the 6 millimeter is important to prevent impingement. So I'm happy. I'll move further to the next. Let's look at this side first. The proximal ring is 160, which is pre-populated from our preoperative planning. The distal support is 160. Again, this is pre-populated from our preoperative planning. It's a ring on and off. You can remove the ring, leave a line only, or you can keep the ring. I always prefer to see the ring, which is good. Here, match the ring independently. I prefer not to. If you look at my ring, if I hold this ring, they move together. If I move them down or up, or if I tilt them, they move together. And I put on the AB and seem to be matching very well for my proximal ring or reference ring. And on the lateral, it's matching again exactly perfect. So I'm happy with this one. I don't need to unsync them. However, if your reference point or if your osteotomy or the magnification introduce some error, you might find them not in the perfect spot. So when you move this one, this move, I never get them perfect. In that case, you can use this function which help you. If you press here, you can move them independently. For example, this one with Eye of Faith, I could slightly lift the front slightly up there. Okay, so I'm happy with that. So this function is useful, but if you do use it, you have to rely on one view more than the other. For example, in this one, I'm going to rely on the AB view. Okay, so I'll come to explain this in more detail. So you come here to the references ring mounting parameters. What does that mean? On the AB view, there's translation 5 mm lateral, and the angle is 0 medial side. What does that mean? This ring here, the center of this ring, is more to the lateral side by 5 mm, and the angle is 0, which means this side or this side is completely flat. This is not down or this is not down, so there's no tilt. On the lateral, this area here, it tells me that the posterior, the ring is translated posterior by 2 mm. So this ring is slightly, if this is the center of ring, it is slightly posterior. And it tells me the anterior side up by 1 degree. Remember when I moved this up to match it? So this 1 degree up has been captured by the software. Whether the ring is internal rotated or external rotated, this is the front of my ring. I want to be my ring exactly in this area between the strut 1 and strut 2. So I need to move this on the anterior to internally. So this is external. I click internal, then I move it. See how it moves? And this is between the two tabs. I'm happy now with this one. Okay, and next part is the reference ring relative to the osteotomy or the fracture is 71 proximal. And even on the AB 71 proximal, on the lateral 71 proximal, this is how accurate we are. But sometimes it will give you a different number. This is what I said earlier. So you have to choose either the AB or lateral. But given both of them the same, it doesn't. You can choose this one or you can choose this one. If they are different between them, what you can do, you can double check it. If you go up there, this measuring device, so I'm going to measure, I'm going to magnify this a bit. I'm going to measure how much between the center of my ring there and my osteotomy. And you can say it's 69. The software calculated as 71. So it's really within 2 mm. If you check the other side, you can do exactly the same with the other side. So you go back and you drop this one. I'm sorry, you need to drop it. You need to highlight this one. Let me remove this one. Select this one. Drop it there, and this is the center of the ring, and this is the osteotomy site here, so 73. So there's variation within 2 mm, so whichever you choose, it will be okay. So I've chosen the AB rather than the lateral. Then I'm going to lock it. Again, it asks me to, I'm going to select the AB. Okay, then I will lock this one. I'll go to the next part. Do you want to save changes? Yes, I'm saving changes. And it will get me to these one. And this is the beauty. The frame you built here, it hasn't changed. I use the same strut size. I use the same strut numbers. So this didn't change, and which saves me time. And after we correct, this is the full correction. Again, I look at my frame. Does it look like this one? I've already checked in the preoperative planning. I didn't change the shape of it. I didn't change the number, so it should be the same. I'm happy with this one. I'll go to the next part. Then we come to the scheduling page. In the scheduling page, you can see this the date of surgery and the latency period, which I set for 5 degrees. Of course, you can change it depending on the patient age and the type of bone you chose. But usually the average is 5 days to allow for the regenerator to start forming. You can apply the lengthening first if you're worried impingement might happen early, and the daily correction rate is 1 mm a day. And I do it twice a day, 10 o'clock in the morning, 10 o'clock in the evening, because these are probably the most convenient time. I don't want the patient to wake up 4 o'clock in the morning to do it. And usually 4 p.m. people are still at work or at school, so these 2 times are good. Then I'll calculate. As you can see, a daily correction 1 millimeter is going to correct by average 4.6 degrees of the varus deformity, and the speed is 0 for rotation because we don't have any rotation, and it will correct in 7 days, and we have only one adjustment as we preoperatively planned. Then we'll go to the next page, which is the report. Again, as you can see, our report is almost identical to the preoperative planning, which is good because the patient put in his head that the correction is going to finish by a certain date, and he's going to have one strut only needed adjustment and no exchange. Again, just a reminder, we went through this table in detail in the preoperative planning, but I'm going to go through it quickly. You have the number of event here, and you have the days here. So if you can see, for each day, if you exclude the first day, the postoperative day, for each day there are 2 events, one 10 o'clock in the morning, one 10 o'clock in the evening, and this is what we set ourselves. You have the strut here, and they are color coded from 1 to 6. For strut number 1, it is medium, the acute 26, and the gradual 33. And you can see the acute doesn't change to the end of the correction, while the gradual change goes smaller and smaller and smaller. Here you have the click, where some patients prefer to use the click to give them the amount of correction, and some patients prefer to use the numbers. And this applied for all the struts there. Here you have the strut number 6, which needs readjustment. Usually you can do the readjustment in any area where highlighted with the blue. The lighter blue one is optional. You can do it here. It's not mandatory to do it here, but if it's convenient, you can do it at any of these days. But when it reaches darker blue, this is where you have to change it, otherwise you cannot proceed with the correction. On the top here, you can print a report for the medical record. If you click on this one and you print this one, it will give you the medical record which full details about your plan, as you can see here. Let's close this one. If you want to print it for the patient, it will be a simple form the patient can easily follow. As you can see here, it's only the gradual correction has been printed. And this is usually clicks rather than, as you can see, clicks rather than numbers. And also the numbers are here should the patient wish to follow the numbers. And the last one for the billing for material used, and this will include the one you use or the one you anticipated to use. So if you have exchange of strut down the line, it will be shown in this table as well. But as we said, we have adjustment but no exchange. The last, we're just going to go through this one, these 2 tabs at the end. One, details and checkup. If you click on this one, you can see at this stage what you have. So this is the first day. You still have 28 degree of varus. You have 5 degrees of carb bottom, no external rotation, no external rotation, and these are the strut number, and this is the shape of the frame. Okay, but if you go down the line, for example here, you can see you're left with 8 degrees of varus, 1 degree of carb bottom. So you can see every day what will happen. If at this stage you decided no, you're going the wrong direction, or you need to change the plan, you can start a new case and it will take you where you stopped, and you can change your program. But we're not going to do this because we are good. And here you can adjust strut. You can change the numbers. For example, here 35, 32. You can change it for different number to make the adjustment at a time convenient for you and for the patient. This is our final X-ray following the execution of the program. As you can see, there's excellent correction on the AP view and the lateral view. There's no varus deformity anymore, and there's no precarbatum or carbatum. And this will bring us to the end of our video. In the first video 23.2, we learned how to do preoperative planning on simple tibia shaft deformity using DLHEX software. And in the second video, we learned how to execute the plan and how to do the postoperative planning to correct the deformity. And finally, and on the behalf of all the postgraduate pediatric orthopedic community, we would wish you all the best for your exam.